Sitch. Why is your internet
Hold
so
on.
bad? Where are you? Oh,
What
yeah.
the hell do
Are
you
you
think
still
I
in
am?
Pennsylvania?
I'm back. She's in Pennsylvania. I'm
I'm in Pennsylvania. Yeah, it's awful. So
They don't have
I
internet
apologize in
there in
advance.
Pennsylvania.
No, I want to be clear. My mom told me that this is better at Wi-Fi than Starlink, and I do not agree.
Your mom is lovely, but she is not telling you the truth.
Yeah, it's bullshit. So anyway, we are going to okay, yeah. Oh, I'm sorry, I was confused because I was looking at something. This is Alex Mugge, the Honorable Alex Mugge,
The
and she's
honorable?
like our special guest. I don't know what are we supposed to call her. I see
She's
interesting
honorable to
people.
me. Like, I don't know.
Don't you think? Don't you? All these comment letters, they're like the Honorable Dr.
Yeah, I'm not
Ben,
doing that.
the
Sorry.
Honorable. Like, I don't know. Like, what does it take to be honorable?
I'm not. I don't know. I wouldn't know.
Yeah, I don't know. Me neither.
We'll
But
take
anyway,
it.
Alex, say hello.
Whatever you want to call me is great.
Yes, say hello to your adoring fans, and then we're going to kick you off so you don't get fired from the job you haven't started yet.
Okay. Hi, everyone. Hi, Kat and Lisa. I'm so excited to be here. I'm trying to hide my excitement. So, but I look forward to going off camera and listening to you guys talk, and I'll be back.
Yay!
Awesome. All right. Well, all right. Lisa, what happened this week? What's going on? What exciting things happened that are
Holy
not news?
smokes. Listen, my no longer new job is a lot of work. It's a lot of work. I worked a lot before, I work a lot now, and wow, this was quite the week. There was so much happening, so many things going on. Dr.
Were
Oz
you business?
responded to Brendan Keeler's like
Okay, that's in our
tweet or
deck.
something. Yeah. Okay, sorry, sorry,
Yeah.
sorry,
So,
sorry.
but question,
Okay,
well, we'll get there. We'll get there. But I do have a question about that and
great.
what you think is going on. So, okay, this is so apparently this was our graphic for last week, but I got it messed up. And last week was National Pollinators Week, according to
Amazing.
Max. So anyway, this is whatever. It's still great. We still look awesome. Okay, so what happened? Current Health got uninvited to Best Buy and re-invited to their old founder.
I mean, so first of all, what's up with our favorite Dr. Ben Zaniello?
Yeah,
Is he still,
where
what's his
is
sitch?
Dr. Ben Zaniello? Where is
Yeah,
that guy?
yeah.
I think he's still, he has not called me lately, so I don't know. He did text
Ooh.
me, and really, mostly what Ben texts me about is his current status on Delta. Whether it's I just got back to Diamond or I'm number 25 on the upgrade list. That's usually what I hear. And so the last text I got for him was he was flying to Amsterdam with his wife for, I think they're at one of our significant wedding anniversaries. And there was no content about work. So that was typical. But it seemed like everything was fine.
Yeah, I actually, so all of us have a friend like that, and my friend is other noted friend of the show, Paul Weiler, because we're both United 1K members. So, and actually, I was trying, if Paul is listening, probably not. I was trying to text him the same thing last night, but the United status tracker was broken, so I sadly could not. I will try and fix that and continue to brag
Yeah.
to Paul about my growing United status.
I think that's important. I think that's
I
important.
think it's
Okay.
important to have a
Well,
friend if
who knows?
you're in that world, you know.
Yeah, but the point here is current health is um now its own thing again. And so this is like a hospital at home situation, right? This is like tech for what I think what Best Buy tried to make it into was hospital at home. Like, do you feel like hospital home was like it was like a bump during COVID and like is not something that's sustainable in the long term? If so,
Well, I
why?
think it's I think it's really so. I mean, I think hospital at home like things are really important, and probably Alex will also agree. I'm guessing, but we haven't figured out the like. I think it's really important, and it got a boost during COVID. But then there obviously are legitimate concerns about fraud, waste, and abuse, and then also they just like couldn't align their reimbursement models and couldn't get enough support broadly. I think it's ultimately, if done well, like really, really great for patients. So I hope that it continues. That's kind of my like relatively uninformed but opinionated opinion.
Yeah, I mean, it also seems like this guy, Christopher McGee, sounds like he's did a lot of interviews. Sounds like he believes. I always like it when founders come back and try to save their thing.
Like, I'm gonna
So
save this. They messed it up. Isn't he like
yeah,
Scottish? Isn't it a Scottish company?
this is a Scottish company. Yeah, yeah.
Nice.
Ask me how I know
Nice.
because Ben talked about how many miles he'd get for going to Scotland.
That's
So
right.
yeah,
That's right.
that's how I know. But yeah, good luck to these guys. We're always rooting for companies that do stuff like this, and good luck to Best Buy because Ben's one of our friends, so we
Yikes.
like you by default. Wah, wah, wah.
That's right.
Okay, yeah. Lisa, you sent this to me. I've got some like nerd stuff in here, like some studies and facts and figures, which don't change my mind ever. But you
You know,
included this in here saying Medicaid saves lives, and we should not cut
that's
it
right.
because we will kill people. Yeah,
That's right. So the people who did this research were like, it's literally just a coincidence that it came out right now. Like we weren't, it's been a very long-term study with like pretty significant data about just simply the relationship between Medicaid coverage and all-cause mortality, as far as I understand. And it is significant. Medicaid is awesome in terms of helping people stay alive and get the care they need. The end. Mic drop.
yeah, yeah. I don't agree with Medicaid cuts. I'll just leave it at
That's
that.
right. That's right.
Another thing, it turns out even with stuff that we're doing to avoid cost increases, we will still see healthcare grow. Well, healthcare costs
It's
grow.
It's
I
bad.
mean,
It's so basically there was like a blip, like there was a COVID blip where and this obviously very retrospective, like it takes a while to get all these data and like reconcile all of it. There was like a blip where they're like, look, like healthcare costs aren't growing as rapidly as they were before. Yay, we solved it. Like VBC won, we did it. And then they were like, just kidding. Everyone started getting care again.
no.
Just kidding. We were wrong. We were super duper wrong,
This
and
is
it's a
why I don't believe
bazillion
in facts,
dollars.
Lisa.
Yeah, they're
This
like,
is why.
so it says
Hmm.
here, right? Just the number. Let me just say the numbers out loud here. As a
Yeah.
result of this increase in health spending, the health share of the economy is expected to have increased to 18% in 2024, up from 17.6% in 2023. We are well on our way to that full quarter of GDP spending on healthcare.
Oh,
We're just going to be the
I round
healthcare
up.
economy. I
I
mean,
round up, so
we're
I
moving,
already thought we were there. Like I was already
dude.
saying it was a quarter. It was just what I was saying. I don't know.
Five
This is
trillion dollars,
fine.
3 percentage points faster than GDP growth. We are just all healthcare and nothing else, and this is
Well,
not good, folks. It's not good.
and are we even counting all the money I spend on vitamins?
We are not. We are
No.
not. And that's
No.
also the
I wonder,
whole thing.
you know,
Or Botox? I mean, how much Botox?
well,
Botox is like another
you
couple
know that is
trillion.
expensive.
It's right.
Yeah,
It's
that's
right.
expensive stuff, and I think important for business. But no, I was thinking about this the other day. Like a lot of these estimates are like based on like health insurance, right? So like that's how they're like calculating the cost. Like, what about the entire longevity industry, the worried well, which I'm a proud member of, by the way, Lisa. I mean, like we spend a shit ton of money. Like I bet we're already. That is why I bet we are already at the quarter. We're
That's
already at the
what Brendan
25%.
says. You have to
Brendan,
spend
that's what
money
I'm
to
talking
make
about.
money.
I feel like I make meaningfully more money when I'm in shape, when I use expensive skincare products, and when I get Botox.
I do not think
I
that that's who
mean,
they're talking about here, Kat. I'm sorry to
no,
tell
okay, they're
you. I
not. Okay, all
think
right.
you are. I
Well,
think you're good.
okay, moving on, moving on.
Big on.
So this is speaking of Brendan Keeler. Oh my God, like he became super famous. Like this guy is famous
Brendan.
for tweeting. I think he said during the CMS ASTP listening thing, he was like, "I'm here because I tweeted harder than anyone else." Like this guy is tweeting his way to fame.
He
Dr.
is.
Oz
He is.
personally was like, "Hey, bro, like your style. Also love that I'm
Yeah.
in a
Yeah.
Union Army uniform. Like, amazing."
Yeah. By the way, Brendan, your tweet still does not have the right link. So go and fix your tweet. I know you're a subscriber to X or whatever. So fix it.
Yeah, like a
But
super
it is
user.
there now. It is there now.
Anyway, if you will, well, in his comment, I think he like I don't remember. I don't tweet anymore, but like he did tweet the link later, which I went to. But if you read this, it actually is pretty good. It's like, hey, bruh, Brendan, I will say I don't know who your leadership is at this company that you're at, but they are wrong, and you were right. You should have totally
Yeah.
sent that letter in because everybody would have fucking loved
I
it,
know.
and they all
I
would have
know.
read it, and you
You should just
probably
send it
would have
under your
meaningfully
name, like
changed stuff.
and make them have to read it. It's as Alex will
That's
tell
what I'm
us,
saying.
like the Govies have to read all the stuff, so they would have read it.
That's what I'm saying.
I mean, in this
Yeah,
case, he did
Alex,
anyway, but you know.
Alex, go find this tweet right now if you haven't read it. Read the letter and tell us what the feds would have done if they got Brendan's actual letter. Okay, great. You got some time. You've got some time. And then because inquiring fans want to know. So
great.
he's
Here he is.
currently commenting. Yeah. Listen, I'm ready. Okay.
That's right.
Cool.
That's
Right. Well,
right.
this was great. Everybody should go read it because it actually was great. And it looks like I don't know if Dr. Oz makes his own tweets, but I hope he does. I hope he does.
Hope he does too.
Yeah. All right. Okay. This week we finally had the hearing, the Senate hearing for Dr. Susan Menares, who is the nominated CDC director. And I thought, okay, so like I know like this is in general like a hard time to deal with the Senate as any sort of appointed person, but I thought she did an exceptional job, and I thought the media actually like took a very kind recap approach with all her stuff, which makes me think she also did a good job, and it's not just because we all like her. So
Yeah.
yeah, I'm super. I thought she did a great job. I'm super proud. She also did, you know, she like not like, you know, she kept her cool, but she did express her viewpoints on a number of things. Like she thinks vaccines save lives. That should make everybody feel really freaking good, right? So I thought she did a great job. Lisa, what are your thoughts?
I thought she did a good job too, as far as I could read. And I mean, obviously, I think she's a pretty great person, nice, smart, principled, all those things. But like, I also am like, what do you people want? Like some of the criticism, I'm like, and there wasn't a ton of criticism. I think she got a pretty good like read,
Yeah,
but I'm like, what do you want?
agree.
She's literally a longtime career civil servant, a scientist who is willing to put her name and self out there like on the line to like lead the CDC for Americans. Like, what do you want her to say? Like, oh, I think this is dumb and that is dumb. No, she is like, this is
She's
the
a
kind like this is
professional.
she's a professional and this is public service and like we need someone like her, ideally her, to do this job, which is like extraordinarily thankless and like gonna be really crummy at times for her for sure. So like thank you, Susan. Thank you, Dr. Menares,
Yeah,
for like sticking your neck out and like Godspeed.
you go, girl. We're here for
You
you.
go.
So
Totally.
yeah, we are here for Susan. Look at the big heart on this slide, and
That's
looking
right.
forward to hearing
That's right.
when. I never, you know, I'm really bad. Politico tells me when actual votes are, but hopefully that's soon, because as you will see in the next few slides, we really kind of need a CDC director to
We could
help
use
us
it.
save America.
We could use one. We
We
could
could
use one.
use this. We
Well,
could
but
use
there's
Susan
also
in this
like
job.
yeah, there's also there's a little like annoying political like thing here that's happening that is it's not even political, it's just like a procedural thing that's happening, which is that she was serving as the interim director and because
Mm,
of the rules around these Senate confirmed positions, and by the way, this is the first time that the CDC director has been Senate confirmed. There's some procedural rules here, so she actually can't really serve as CDC director right now, even though she was slash kind of is interim director. So we needed this hearing to happen and we need actually the vote to happen so she can get in there and actually do her real job. There's all kinds of procedural reasons why she has not been able to serve in that. So hopefully they'll schedule it soon. And basically it's just like whenever they can schedule it, whenever they can work it around other things and whatever
yeah.
else. So like fingers
Well,
crossed.
well, listen, while everybody's bitching about vaccines in the Senate, I hope they all find some time to have this vote, because that would be great.
Yep.
Okay. All right. So moving on. Okay. So we have a special request. I had to pause here because I was reading Melissa's comments. Melissa says, Brendan, why have you not responded to our email inviting you to have a debate with Kristen Valdez from, oh shit, I just
Be
forgot the name of her
well.
company.
Be
I
well.
was going to say
Be
Be Held,
well.
but that's Minnie's company. Yeah. Why have you not said yes? I am confused. I know you're having a baby, but listen, I had 2 of those babies. They came out of my own body and I still worked every freaking day. I worked on the day I delivered. So I just want to know, what kind of
Wow.
new agey bullshit are you pulling that you're not going to come on the talk show to
I
debate
mean,
with Kristen?
honestly, like to be fair, I've been on like 7 calls with Brendan in the last like 2 weeks, so I know he's working, and I know his family is also expecting a baby shortly. So probably those are the
Listen,
reasons.
I'm
But
just
yeah,
saying.
Brendan,
I'm not
just saying.
sure if you know this, Lisa, but I walked uphill both ways in the 100-degree heat
Jesus
and in the
Lord,
snow. And I just don't think that it's an excuse that a man can't come on our talk show to debate Kristen. I'm
you say
confused.
that to
So
Brendan's wife right now. Say it to her face.
Brendan's
Let's see
wife,
if you have the cojones.
I need, oh, I will say it to her. Lisa,
Sorry, the
have you met
ovaries,
me?
the
Anyway,
ovaries. Excuse
Brendan's
me.
wife, I'm sure you're a baller. I'm fucking here for it.
Brendan, tell us her name
just,
so we cannot call her Brendan's wife. She's a
Brendan,
person.
look, listen,
You-
I'm pro all this shit. I just need you to do this. Okay,
Brendan, tell us
anyway,
your wife's
moving
name.
on.
We want to give her the respect
Yeah.
she deserves as a person
Listen,
who
we
is
will
about to have a baby.
we will put her on a dragon with your spawn on other dragons, and
Oh my
we'll
God.
show you doing the dishes. I don't know what we'll do, but like we will honor this woman. She will.
Show him
This will
changing
be
his
good.
diaper.
Yeah, we'll show him doing all the work. Okay, anyway, moving on. God bless Susan Manaras. Bailey, we are. I assume her last name is Keeler. That's a bad assumption, but listen, Bailey
That's a bad
Keeler,
assumption.
come on our show. Oh my God.
I think Kristen,
oh.
Brendan says he has no debate. I think Kristen will have a debate with you. Whether you like, I think she'll push you on this.
Listen, I've been having debates with Lisa on capitalism for like the past year, and it turns out we agree on that. So like there, and people still watch our show. So like, I feel like this too can be an amazing show. Okay. Anyway, the point is we're fine. Okay. All right. How do we get
That's
this?
right. A
My
whole
screen
human
is very
being in her
small.
own right.
That's what
That's
I'm
right,
talking
Ashley.
about. Boom.
That's right.
Okay. All right. And then we got some damn children. I'll tell you what. Okay. By the way, children are the reasons my Wi-Fi is not as great as it could be, also because I'm in the boonies. But I go home tomorrow. Don't worry, America. Then I'll be in southern infrastructure, which is just as good as rural Pennsylvania. Okay, moving on. Okay, so I'm like, obviously I'm going to talk about myself here, but then we're going to talk about other shit. So this week, a bunch of me and my besties, Lisa was doing work in the private sector all week, so she did not come. But we went to ASTO, which is the American Society for Territorial and Health Officials. I don't know, something like that. It's a long ass name. Anyway, they invited us down to talk about communicating public health interests to all kinds of different audiences. So I brought my besties down. So Matt Christensen from West Virginia, he's the CMO of Valley Health and former state health officer of West Virginia. Dr. Kavita Patel, who is at NEA and also on NBC and also like worked for like the government. Darshak, everybody freaking knows Darshak. Also, he's like a professor at UMass. And then Nora, how could I forget? Nora Cox, who is a PhD from the School of Hard Knocks. So Dr. Nora Cox to communicate about legislature. So we taught a bunch of public health executives, like, how do we do these things? And we did all these workshops. And the key to this workshop, y'all, so there's gonna be a point, Lisa. This is why I get to make the deck and you get to stare at me like, what the hell's going on? By the way, Scott, I see you saying go Nora. Everybody said that. Obviously, we had a competition at the end of this workshop, and obviously Nora's table won. Which should surprise absolutely no one. But the key, there's 3 parts to this presentation. It was like basically a little framework that you could use as you communicate priorities, even though like you're under a lot of pressure and like shit is going crazy. And it was sell, AKA engage, make bagels. We'll talk about bagels some other day. And then think small, AKA prioritize. So the first part of selling was engaging and being willing to engage and not leave the conversation and not have polarizing conversation. So we're going to go into ASIP and some coverage of that. And I'm going to tell everybody that I think the American Academy of Pediatrics is total fucking bullshit and did the wrong thing. So it's very exciting, Lisa. I'm looking forward to your thoughts. Okay, so ASIP, they met, they made decisions. They decided that they are going to like abolish Thermosol, which has long been tested as safe. And there is no evidence to the contrary, except for people on the internet like me. I mean, I'm not saying it's not safe either, but it's people like me who have no credibility saying that it's not safe. So anyway, Lisa, any commentary on this?
You're doing your own commentary. I'm just gonna let you go.
Yeah. Well, anyway, okay.
I agree with
so
everything you're saying. Keep going.
Listen, you guys, I like often don't believe in facts. It's true because I'm a PR girl, and I can tell you the number of times I have twisted facts around to fit my own purposes. So like facts aren't real. Another thing that we presented at ASTO was that like facts actually don't change people's minds. It actually is like fucking science that you can't throw a bunch of facts at people and make them change their minds. They just go, fuck you, and further entrench themselves. There's like a whole different, I wrote a fucking LinkedIn post about this, about how Lisa made me change my mind once. Maybe a couple times, but there was one time in particular that was very exciting. And it wasn't because she gave me a bunch of facts. It was because she aligned with my belief structure and chose to engage with a crazy person like me for fucking years to make me change my mind. So anyway, this, RFK, he like abolished the old ASIP panel. He got a bunch of other guys in there. One guy left. There's like another guy left who decided to like state his mind here. But in general, the big thing that came out of this was that they said no more Thermosol in any vaccines whatsoever. So the only guy who pushed back was this guy, Dr. Cody Meissner. I'm probably saying his name wrong. Do you know, Lisa? Anyway, this guy, Dr. Cody Meissner, he was the only one that said like, listen, y'all, that's bullshit. And good for him. And I think there was only like 7 or 8 of them on the panel right now, right? It's not fully staffed. as far as I know. So this guy said no. Obviously, they still voted to have it taken out, which, like, whatever. And then he got a lot of praise for, like, speaking his mind and saying stuff. But the interesting thing here that I think is bullshit is that the American Academy of Pediatrics chose not to participate. So a bunch of these organizations can participate, but they're not voting, right? And so the AAP was like, fuck you, we're not coming, which was, I think, bullshit based on what I just taught all of these public health executives, which is that you have to engage in order to be heard and have any perspective, and deciding not to go and write your own fucking recommendations on the internet just further polarizes our country. So fuck you guys for not being good at stuff, is what I have to say to you. So what I love about this guy, Cody, is he says it's somewhat childish for them not to appear. It's dialogue that leads to the best recommendations for the, I can't read the end of this because my thing is over, the use of vaccines. So totally agree. And y'all at AAP, this is science, that's how you actually make impact, by engaging and participating in respectful dialogue. And this is what the AAP said back, like a...
Oh, we lost her again. The internet hates Kat right now.
Oh, I'm back. I'm back
Kat,
now. I'm
you're
back now. I'm back. Listen, this is part of
in the
being in rural
middle,
America. Lisa.
in the middle of your rant, the internet cut off. So keep going.
Okay. Well, anyway, okay. This is the AAP's response to them, to Dr. Cody Meissner saying that they were being childish.
Sure.
They said ACIP has drifted so far from its longstanding focus on science, evidence, and public health. When that focus returns, we will too. Listen, dude, what's going to happen is half of America that voted for Trump doesn't even hear you anymore because you're off in La La Land sending out notices on freaking the internet and probably Blue Sky, where legitimately no one you need to persuade is.
Blue Sky.
And half of America, I make fun of Blue Sky all the time. I'm on Blue Sky too, but like I'm also on everywhere else. Like if you want to engage, like go somewhere else. Like everybody who thinks like you is on Blue Sky, like that's it. But yeah,
Lost her again. This is bad. She's getting in all of these like screaming matches here and with herself.
Oh my God,
and
Jesus
on the internet.
Christ.
Dude.
Okay. Anyway, the point is you understand what I'm saying.
I'm going to finish this one for you. And that is, you're saying it's a luxury to be able to opt out, and the AAP shouldn't be opting out of where everybody is, even if they disagree.
That's what I'm fucking talking about. Yeah,
That's
listen,
right. That's
if
right.
you care about America, all you people at the AAP, you better show the fuck up to the next meeting. Like, what
That's right.
the hell? Ugh.
State the truth.
Yeah, what the hell? You are being childish. Grow some freaking cojones or whatever organ you prefer to sound dramatic and go to the next meeting. All right. The last thing I'll say about this ACIP meeting, which still made me mad, is that the argument that I'm hearing, so I actually disagree with their recommendation that they should take out Thermosol, right? Like, because, once in a while I believe in science and facts. However, the argument they're making is that they should keep Thermosol in for the poor people. This is like the worst argument I've ever heard in my life, Lisa. It's basically saying, the version of the vaccine that everybody thinks is causing autism, even if it's not, but the one like most of America thinks is bullshit. We should keep that one so we can give it to the poor people. This is the worst communications exercise I've ever heard in my life.
I mean, listen, I don't know. Sure, it doesn't align with all of the conversations we've had about the importance of storytelling and making your case and communicating in public health, right? Like, it's not a good example. Now, if you could say, like, it's a billion times more expensive to produce a vaccine without Demerasol, whatever it's called, then maybe there's an argument there, but like, you've got to tell that story in a meaningful way.
Yeah, agree. Not just like, let's give it to poor people. Like, no, maybe we should give poor people the one that people trust.
There's not a great history of that kind of thing in public health in America. Just a little history lesson.
Anyway, so that's it. Listen, people at the AAP, if you want to come on our show and tell me why I'm wrong, I am fucking ready.
Let's talk.
Do it. Let's freaking go. But please, without me cursing too much, please go to the next meeting. Please participate and engage. So at least your comments are heard by the chunk of America that does not trust you right now. Like, because, they might
Yikes.
never trust you. So, that's what I think about that. Okay, moving on. What other exciting things do I have here? Oh yeah, the last thing is this is this op-ed. It was actually in our presentation. This is about polarizing stuff in America. Sorry, Lisa, I turned this into a rant about engaging with the public, but like, so did you guys read that? Did anyone read this op-ed in the New York Times? Lisa, I feel like I know you did. This was Bill Maher had a dinner with Trump or something, and he came back and said, "Oh, he's actually a reasonable guy." And then this guy, Larry David, wrote a satirical piece in the New York
This
Times.
guy, Larry, wait, let me stop right there. You said this
This
guy,
fucking
Larry David. You
guy.
don't know who Larry David is? Larry
I'm just saying,
David,
this fucking guy. This guy.
the
This is an
comedian
example
version
of
of
like.
Bernie Sanders.
Okay, you guys. Okay. I know there were a lot of rich Democrats who read this op-ed and like patted themselves in the back and like drank their mimosas or whatever the hell rich people in New York City drink. And they were like, right, this is fuck Trump. We're not going to engage. Like, listen, this is another example of polarizing language in America. This op-ed persuaded absolutely
This is
no
a
one that needed to be
satirical article.
persuaded.
Cat, it's
I totally agree,
satirical.
but the message was that don't engage. Like, fuck you, don't engage, which is
Sure.
exactly what the AAP did. And exactly what, honestly, like most people who don't agree with the other side do. Like, this is not how you get things done. Like, this is just how you get
Well,
things
I
done.
mean,
And
just
like
to be
on Blue
clear,
Sky, you get a lot of
no.
likes.
Right, just to be clear, like putting a satirical like op-ed in the New York Times is certainly not an attempt at communicating with quote unquote the other side. That's a like my
You're right. It's
friends,
what this is. I'm sure the
my dear
intent here.
friends are gonna read this and think I'm funny. That's like what this is, as far as
Yeah,
I'm
they're gonna think
concerned.
I'm funny, but still, the message is don't engage with the bad guys
Yeah,
because we're comparing them to
yeah,
Hitler.
yeah,
So
yeah.
this is just like, I don't know. This again was like just bullshit, and this is why people don't like each other, and it makes me mad. So here I am like slamming the AAP on the internet, but that's fine. We just have to do better, y'all. You just have to engage. Like, be like Susan, like come in and try to be like a voice of reason, like a moderate person who's going to do stuff and like try to save America. I don't know. I'm mad
But
about
also
it.
at some point, like somebody, I'm not trying to give Susan advice here because she is the one who's out there doing this, and I'm just a lazy commentator on the internet. But like, I mean, you just sometimes do have to like block out the noise here, like as I assume she is doing, because she's not going to make everybody happy. Nobody who's trying to like reach across, different interest groups is going to make everybody happy. Somebody's going to be pissed off, or people are going to be complaining and whatever else. You know what I mean? Like, so I hope she can
Yeah.
hope people like that can block out the noise and be like, you know what? I'm going to try and do something good for everybody.
Well, yeah, a lot of people complain on the internet, and that's like, that's the go-to move. So, what did Brendan say? Is anyone really okay? This is what I'm talking about.
That's right.
What even are facts? This is what I say all the time. What even are facts? I don't know. Like, I don't even know.
I don't
I don't
know.
even know what they are. Okay, Lisa, what do you think the facts are? We'll bring Alex on because everybody's here
I
for her
mean,
as usual.
I mean, the facts are we are going to have a lot of problems if we don't get our act together and start addressing public health. And if we cut our investment in critical vaccines, it's gonna show up in the form of another pandemic real soon. So everyone get ready, stock up.
Yeah, yeah. We should probably we have a lot of work to do. Okay,
Lots more to
all
do.
right. Yeah, Lisa, anything else happened this week? Because we were both in and out
God, so
doing
many
stuff.
things happened. I can't even remember anymore. Just let Alex tell us what happened.
Agree. Alex, what happened?
I have no idea. I am between employment right now, so I went to the pool every day.
She's like, I'm just chilling. It's vacation time.
I went shopping today. That was great. And then I'm back to like real world employment next week. So
Amazing.
Oh man,
Amazing.
like on Monday?
on Monday, yeah.
At least it's a short week. You chose that's good. You gotta
That's actually
you
a
gotta
great
meter
week to start.
yourself.
You're like,
Yeah.
nobody's
Easy
there.
Fun fact, Memorial Day and the 4th of July are the only days that I don't actually work.
Amazing.
That's very patriotic.
I know. Yeah, except Lisa's going to come to my house. She's going to be at my house because you're going to India, right, Lisa?
I am. I'm going to India. It's a great time to be traveling to another country.
Yeah. Listen, I feel like the India's got your back, but she's going to come to my house and she's going to be there 4th of July. It's going to be the best.
That's
And Yeah. And so we might work because we will talk about work, but it will
That's
not
right.
be billable, which is important. So I
That's
feel like
right.
that's
That's
good.
right. That's right.
All right, Alex, tell America who you are, what you've done, and what you're doing next.
Okay, so I am a former chief health informatics officer for CMS. I was a federal employee for 15 years, which
That's amazing.
I still can't believe. I was just I've been telling people, I always thought I would leave after like 5 or 10 years. I worked at Humana before coming to the federal government, and I remember when I left private sector, I was like, yeah, I'm gonna go get this government experience for like 5 to 10 years, and then I'm out. But 15 years later, I was still there. So I've been taking the last 2 weeks off after all that, and I will be starting work at Oracle on Monday. So that's exciting. 2 weeks is
Amazing.
still long enough between jobs. So if anybody is like looking for a job change at some point, you might want to do more than 2 weeks. But here we
Yeah.
are.
I did negative 2 weeks, so I think that's even worse. But I yeah, definitely. It's so cool. And I mean, honestly, Alex, you were at CMS for some really critical things that happened in the interoperability and patient access world where we work together. I mean, talk about like anything you can talk about publicly that we did from a regulatory and sort of advancement of interop perspective, because you were involved in so much.
Yeah, that is true. And Lisa, that's how you and I met, was working on the patient access piece. But backing
Mhm.
up even before that, I mean, so being at CMS for 15 years, I saw a good chunk of the life of the meaningful use program, which I think one of your guests referred to as the original sin at one point. Yes, the meaningful use
One of
program.
our
Joe
guests
Grogan.
named Joe Grogan, who was like, "This thing sucks."
It was a few weeks ago. You referred to as the original sin. I actually thought that was pretty spectacular. So, um, you know, uh, So for the last 8 years ish, I've been working as the chief health informatics officer with CMS, and also I should mention the director of the health informatics and interoperability group, which is a team of spectacular people who like help coordinate all of those interoperability rules and policies that you see coming out of CMS. But prior to that, I was working in our before that role even existed. I guess I was working in our clinical space on the quality programs, including meaningful use, MIPS, hospital value-based purchasing. And we can get into a whole thing about quality measurement and those programs at some point if we want to. But just thinking specifically about meaningful use, that did start out as this program to get people to adopt technology. And again, that was something that you guys talked about. And like if we needed to pay people to adopt this technology, like maybe that wasn't quite the right way to do it. And I thought that was a really insightful comment, because the technology should be in place to work for clinicians, but in a lot of cases we're seeing, that it just creates more work for the clinician instead. And that's not what that program was intended to do. But we started with meaningful use. Then at one point we transitioned, or we changed the program, really just changed the name to promoting interoperability. But we did try to change the focus as well to be more about interoperability and the data exchange part of using the technology, not just the like, did you e-prescribe or did you document something in the electronic record, but how are you exchanging that data with another party? And I don't know that the measures even now are really there. I mean, we can, like I said, talk about measurement and those programs and think about how they might be reimagined in the future. But for a long time, that program was really focused on meaningfully using the technology. Did we get there? I don't really know. Even after my 15 years at CMS, I'm leaving knowing that there's a whole lot more to do. But it'll be exciting to see things from the other side, to actually work on the implementation of those programs, see how it's working. That all also, of course, coordinates and ties into the certification program from ONC, which I think you guys also covered a little bit, which I would love to talk some more about, and maybe the future of that program. But then moving on from that time, we did start the interoperability office at CMS. The Health Informatics and Interoperability Group is a big part of that. And we have published the interoperability rules that started to bring payers into the mix. So for a long time with meaningful use, we were only talking about clinicians and hospitals. We didn't talk about anybody else in the ecosystem. That was it. And so back in 2020, we started publishing policies to get the payers involved, have them building APIs, talking about standardizing data, talk about getting them to exchange data with those EHRs, and a big part of that was through the patient access piece that Lisa was talking about. So
That's right.
we can argue with patient access. We all want patients to have access to their information, so that's where that program started, and then we expanded to provider access and to sharing data with other payers. And then, of course, in the most recent rule, we finalized policies to require electronic prior authorization. So going from the first rule was really sending data in one direction, but the prior authorization rule brought in that bi-directional exchange and requiring the payers and the providers to work together on an administrative task, which we selected prior authorization because it's been historically a very burdensome administrative process. And we thought that the electronic processes, the FHIR APIs that were in place.
This is my prior authorization denial that I
Oh,
just got via paper. Via paper?
yeah.
And to be clear, Lisa, that's for a relatively low stress situation, right? Like it's and low cost,
Yeah.
right?
For your prior authorization, or sorry, say that again, for the APIs that we're developing. Say that one more
You
time.
mean my prior auth? What are you talking about?
Yeah, for
Oh.
prior authorization.
No, I was just saying, Lisa, your prior auth situation that keeps getting denied is a low cost, high impact,
Yeah.
low risk
Yeah.
situation, right? Like, and
Oh
it's
yeah.
still
I
they're
mean,
like,
yesterday
nah.
I was like, no, yesterday I was like almost blind. Like I genuinely my eyes were so dry. It's because I've had chronically dry eyes for a really long time. And I finally went back to like a real ophthalmologist. And I'd been on this drug before, which is now a generic drug, like a decade later. Like they finally like released it and now it's
Yeah,
generic.
right, prior
And I
authorization.
got prior auth for a generic drug and it was and I read this and I was like, I don't even understand. Like I read this and I'm not normally like very sympathetic to like medical doctors. Just like I don't like blindly revere medical doctors. Sorry, medical doctors. Like I appreciate you. I respect you, but like I'm not like blindly like, oh, you're amazing, you know everything all the time. I read this and I'm like, does not meet plan coverage criteria for coverage due to a lack of medical necessity. And it's like the prescriber, a medical doctor, a specialist, like put in the prescription, thereby indicating medical necessity. Like I understand they wanted them to, fill out some other form, but I'm like, what do you mean? That he was just like, you know what, it'd be fun to just waste some money. Like that's not what this guy is saying. It's just like it's wild to me that this still happens. And then that's bad enough. But then the fact that this piece of paper came to me, and when I tried to figure out where it went, I asked, they're like, we haven't received anything. So somebody was faxing, I assume, faxing, our favorite topic, something to some who knows where fax number and not getting a response. And they obviously didn't try at all to do an electronic prior authorization. All they did was faxed a couple times, and then they send this denial to me. That's it. And
Well,
it's
most
just,
programs do have requirements to send paper in addition to anything electronic that's done. Not that that's going to make you really feel any better, but I'm just saying, there may have been some electronic thing somewhere in that process, but you're right. It was more likely fax or portal that,
they told me it was fax, and the doctor said I never received a fax anywhere. So, it's just like it's just this is still happening,
it's
as
just
we know. Like
happening.
we've been pushing this boulder up the hill for so many years, and you've been trying to do something about it and trying to help, but it's like, here we are.
Well, I agree. And that's why I'm saying it's hard to leave this job
Ah,
after these years because in the 15 years that I was there, we did see it, increase adoption of the technology through those programs and our $36 billion investment in EHRs. And then we moved into the payer programs and these APIs, and the APIs for prior authorization aren't even in place yet. Those will go into effect in 2027, and hopefully we'll see some increased productivity there, maybe a more streamlined process. But prior authorization itself isn't going away. So really, these APIs are only there to make the process easier and ideally quicker. But it's still going to be there, and you're still going to probably get those denials, and you're still going to have to do the peer-to-peer. And hopefully, though, it won't still be going through a fax machine.
So, Alex, what do you think of this big old announcement that was on like Monday? from like Oz and Chris Klump and RFK was there, and they were like, "We got the payers to say they're going to fix prior auth." What do you think of that?
I think that is really cool if it works, and I hope that it does. I think there's a lot of interest from payers to change prior authorization, especially given recent events. Everyone's sort of taking another look at things. One of the goals that we had when we were writing the prior authorization rule was to say, if all the payers are going to be migrating these paper portal fax processes and standardizing them and putting them into these APIs, maybe they'll look at them and be like, we've got like 10,000 of these and this is exhausting. Let's cut it back to 5,000 or something. So we were always hopeful that payers would take this as an opportunity to reevaluate their prior authorization processes. I think it's always great when we as I can't say we, hold on. They as CMS can work as coordinators to like conveners, bring people together, have the discussion, and have folks voluntarily come to the table to do things. Because when you're doing things in that way, you're buying into it a little bit more, as opposed to when CMS regulates things, it becomes a requirement. Sometimes those requirements get outdated. Sometimes not everybody's on board with them. Sometimes they're necessary. But in this case, what they're talking about was a convening and talking with the payers to say, let's rework the prior authorization process. And awesome. Let's hope that that works. Let's also hope that it sticks. If it's not in regulation or in statute, it's not a requirement. So we'll have to see how much payers can really make a difference in these coming years and how much they buy into the process. I hope they do.
Yeah.
Well,
Awesome.
and my understanding is that there isn't a dramatic difference between the provisions of CMS 0057, which was the prior auth rule, and what was discussed on that stage. And that's fine if you want to do a big, press conference or whatever and get people to like sign of, whatever, something else, like, cool. I'm fine. I genuinely want it to change. Like, I don't care how it happens. But I
Yeah.
don't think there was a dramatic difference in like things that were being committed to versus what is actually required in like existing CMS regulation that has not yet fully come into effect. And I mean, I understand, I know everybody who was involved in like pushing on the dates. And I also know from working at CMS as well, like how hard it is to like hard require totally new things that require, real technology investment, right? It's not trivial to say everybody needs to adopt this like right now, starting next year. Like the deadlines don't work like that, right? Like it takes longer than that for a big company, especially one that's responsible for health insurance coverage to make changes. But to be fair, there's been plenty of pushback from the insurance industry in the past about those deadlines. Like they want them to be further out, they want them to be less restrictive. Of course, that's what industry wants. They want less regulation from the government. But at some point, we have to like all actually come together and do stuff and have everyone move at the same time because otherwise we have, still endless facts and like incomplete integrations and implementations.
Yeah. Well, exactly. And, but a couple things that you said there. Everyone wants more time on their deadlines. I think with prior authorization, that's one of the reasons that CMS wanted to bring folks to the table was to say we don't want to extend these deadlines. Like we want to get it done. So having folks sign on to early implementing and testing and making sure that when we get to 2027, it's implemented in a way that works. Implemented correctly. But there are complicating factors to that. I just hold on before I move on from that. I just want to say Dr. Oz did say that there were some things that weren't mandates. I know that some of the things they're asking payers to do is to look at like, can you actually reduce your prior authorizations? Like, do you really need all of this? If you're approving this 99.97% of the time, can you just get rid of that? Can you do the gold carding? I think he also specifically mentioned gold carding. That's something that we mentioned in our proposed rule that went out 2020, end of 2020, maybe.
Yeah.
Mm.
It was in 2020.
I might have blocked some of that out. We've talked about gold carding. We've talked about honoring prior authorizations that come from a previous payer so that people don't have lapses in their coverage when they're moving from one.
That's a big one. That happens all the time.
Those are
Yeah.
not requirements though. And, Dr. Oz
Yeah.
is very clear that some of these things aren't requirements, but we just want you to do them. So it would be awesome to see payers step up to the table and say, yes, we agree, we can do this and we can make the process better for patients. And for the providers who have to do all the paperwork. But that is yet to be seen. So hopefully they they come forward and they make it happen. But the thing I wanted to mention also about deadlines is ONC still doesn't have the ASTP. I don't know what to call them. ONC/ASTP still doesn't have their final rule out on electronic prior authorization. So their HTI-2 rule did talk about electronic prior authorization in the certification program. That was never finalized though. And so that is a major missing piece. The payers, we know, have to come to the table on January 1, 2027. The providers, however, don't have the technology to do it yet. And so that's going to be a major factor in whether this is successful. And I really, really hope that it is, because there's nothing worse than having like a launch of something in January 2027 and like only half the party shows up, and it just doesn't work. We need to make sure that we've got the EHR side in place as well.
Yeah. Hey, Alex. So you said we spent $36 billion on the original sin, as per Joe Rogan. What would you have done with $36 billion if we go in the Cat and Lisa time machine to like, whatever, 2008? What would you have done with all that money? Would you have done the same thing?
I'm not going to say one way or the other whether I would have done the same thing, but I will say is, I mean, for it was a lot of money. That's a lot of money. That's a B.
Yeah, that's more money than I have, America, to be clear.
Yeah, that's a lot of money. So, I mean, it was a lot of money, but we did see the technology adoption happen fairly quickly. People often talk about the post-acute care side not adopting technology as quickly because they didn't get the money, and maybe the story for another show. But but I do think that it certainly helped in getting the EHR developers invested in this process and getting the clinicians on board and getting the technology into the hospital. So I'm not going to say that I would have done something different necessarily. I think I might, reevaluate some of the measures that we've looked at over time, and reconsider like, what are these measures actually getting for the patient, and what are they helping to streamline for the provider? Because a lot of the program, I mean, programs have two parts. There's like the health IT, more commonly thought of measures, like, are you e-prescribing? Are you submitting public health data? Those types of things. Some of those are kind of more structural, like yes, no measures, whether they're happening or not. And there's also the clinical quality measure side, which when we switched to MIPS, like some of that all got rolled together and whatever. But we're measuring these clinical quality measures like just based on what's collected in an EHR. I'm not always sure if we sat down and looked at all of the requirements with the EHR community and with clinicians, that we would all agree that we're collecting the right things to provide better patient care, to provide a more streamlined user experience within the EHR, and that we're really getting what we want out of that from in the regulatory space either. So I think it's a good time to sit back and look at all of the measures that are out there, and the way that the EHRs collect the data to say, what can we streamline here? Like, how can we reduce some pop-ups in these processes, and still get the right data to support clinical work streams and patient care? Forget the measures for a minute. Like, let's actually go back and say, like, what does the patient need? And that's something that I would do across the board in all of the quality programs, like not just meaningful use. Like, let's just say, what do we want the patient experience to be? And then build measures on top of that, instead of building the measures and then like having that funnel down to the patient experience.
Why does it work like that?
The workflow. So it's because of workflows, as Alex is saying, right? Like all of the digitization of the healthcare system so far has been based on, as far as I can tell, for the most part, until very recently, replicating existing paper workflows that were designed, paper-based workflows were designed for like a different healthcare system of the past, right? Where we didn't have as much billing pressure. It's easier to just do that, just to digitize that, like make it a digital thing.
But is it also a dumb comment thing with rulemaking where lobbyists get to fuck shit up?
Yes and no.
Yes. That's true.
So there are a lot of measures that have done incredibly good things, right, for patient care, like making sure that a patient gets aspirin if they're brought in, with a heart attack. Like those are things that have actually changed patient care and helped raise awareness, and have improved outcomes. I mean, I personally love electronic prescribing. That's one of the meaningful use measures that I always thought was like dead on. Like, it's great to not walk out of the doctor's office with a piece of paper, but instead just have have the prescription waiting for you when you get there. So like some of these things truly have done incredible things for patient care, but there are also the quality program requirements where we we as a country have held, like, we have to collect all of this data to change physician payment, to adjust, value-based purchasing agreements with hospitals and whatnot, and to to try to make everyone happy, we keep adding measures that we think will be, more easily reportable or more applicable to them. And so we end up with a lot of measures, and that's just hard to manage. And some of those, and they get reviewed all the time. But are we always reviewing them for like the applicability and for the right things? And then
And there's not like an up or out rule either, where you're like, you can only have 10, so you better choose which ones you want to get rid of. It's like, no, we just like keep adding them, right? It's not
We
like
do.
a,
We have
yeah.
a lot of measures, and a few years ago, CMS did the meaningful measures effort where they did look at all the measures and try to cut back and streamline where appropriate and everything. So these efforts have happened over the years, but it's just there are a lot of quality programs and they have a lot of measurement in them. And I should just say, like, I'm only talking about like what I've seen and what we've all seen at CMS. We have quality programs for like every facility type, but there are also the payer measures that they're collecting, and then there's also state requirements and other things and internal controls and whatnot. So like these EHRs and the technology that we're using is trying to cater to so many different things, and sometimes we have to take a pause and say, like, is it still catering to the patient and the provider the way that the programs were originally intended?
Yeah.
Always worth it.
Yeah.
The review.
All right,
Definitely.
Alex, you've been at the pool for 2 weeks, or
Okay.
you're what lounging in the pool margarita? What is the
Yeah, we cannot hear you, girl. You gotta get those kids off of whatever online game they're playing.
Listen, am I back? Am I back now? Am I
Yes.
back? Okay. What's the thing you're most proud of in your 15-year government career?
I think just getting the focus on interoperability is really important. I mean, data exchange technology, it underlines all of healthcare. Like, I don't think everybody's like really willing to admit that yet, or like understands, but like the technology is there. It's going to impact everything. If you want quality data, you got to use the technology. If you want payment reform, you got to look at technology. The patient experience, everything is about having access to data. That's what we see in other parts of our life too. So we're finally kind of getting there in healthcare. I don't think that's where the focus was 10 years ago. And now we're finally getting to a point where we understand that for healthcare, technology is where it's at. It needs to happen. Brendan thinks I should be most proud of CMS 0057. But even before that, like setting the foundation of the APIs and the patient access rule that Lisa and I worked, we used to like text at like 2 a.m. talking about these rules and the policies in here, how to make them bigger, stronger, get engagement from the payers. Like, that was a big deal. And now
It was
having
a big deal. It was a big deal. And it was really like, I don't know. I mean, there was a lot of momentum around that, but it was also based on, it wasn't like you were coming from nowhere. You've been doing the work for a long time in CCSQ and elsewhere, right? And that's government, that's CMS talk for a division that focuses on quality. But like, it's just, it's like, it doesn't come from nowhere. Like, people have to be dedicated to it for a long time. It's a lot of knowledge and background information you have to have. And like Alex, I mean, you did that for quite a long time, and you were super credible in that role. And I mean, I just, obviously, we've said it a billion times here, but like, you know, you're an exceptional, like, really, really talented government employee who like should have been supported to be there for longer and do what you wanted to do. I mean, obviously you left on your own terms, but it's like, I just, people need to be aware, like, somebody like Alex is like working her butt off, like, on behalf of the American people. And there are other people like her as well, who are really qualified and hardworking and care about the outcome, which in this case was like, what can we do, like, day by day to like continuously trying to improve and expand and grow like interoperability and exchange across, CMS systems. So,
well, you're
Yeah.
way too
well,
generous
This
because
is
like, it takes like 50 people to write one of those rules, and like
Totally, but like, you
I got
know, you need a leader. We need leaders. You're a leader.
absolutely.
But no,
And
this
we love all of that, but like in even leaving, I was going to leave back in May, and then I stuck around for a little while to help with transition and make sure that because this work is so important, we wanted to make sure that we had new leadership in place to keep all this stuff moving. But the first time I was getting ready to leave and I was approaching my end date, you guys know this, but I went to get my mammogram, which is annual screening, and I walked in and I paid my extra $40 for the AI screening and whatever, and I wasn't wearing my deodorant. I followed all the rules, showed up ready to go for this mammogram, and I go back into the dressing room, and the woman comes back and says, "Well, we can't do this today." And I was like, "Why not? Like, again, no deodorant. I'm ready to go. Like, let's make this happen." And she said, "Well, the last time you had a mammogram in Maryland, which was a couple of years prior, because I hadn't lived out of state for a while there, she said you were scheduled for, or you were told you needed to do a diagnostic follow-up, and we don't have on record that you did the diagnostic follow-up. Thus, we cannot do your annual screening, even though it's now 2 years later." So I said, "No, I did have the diagnostic follow-up, and I told you that when I scheduled this. I told you where to find it, whatever." So she goes back to research this, and same situation, Lisa. She found the fax that they sent to the breast center in Florida, but they hadn't gotten a response with my results from that diagnostic follow-up, and thus they would not do my screening mammogram. So the fax is sitting somewhere in Florida. No one had seen it. So they wouldn't do my mammogram, and I had to leave that day. And I left so frustrated that I start texting people at CMS saying, "We have to fix radiology and interoperability. This is ridiculous that they're faxing and trying to get my images sent on like a disc, of course, right, from another state." So I started comparing that to NASA can take pictures of like looking for microscopic life on Mars and then beam them back to Earth, but they can't get a picture of my boobs from Florida. So I think we are just fundamentally broken in that space, and so part of me really wanted to stay at CMS and just say we've got to get this fixed, and keep working on things like that, because no patient should be turned away from a screening because a fax wasn't picked up. That's stupid. But here we are, and doing this today, and
It's genuinely it's so freaking infuriating at this point. I mean, it's a special like level of hell if you've been working on like interoperability and then you literally are every turn like as a patient you're like, are you freaking kidding me? Like what are you doing? And it's also just the workflow that's just so dismissive of patients. Like cool, I showed up, I didn't wear my deodorant. By the way, if you don't have boobs and haven't had a mammogram, you can't wear deodorant. I don't know why. Someone can explain it to us.
I don't
And
know.
you
Do
know,
you
you
think the
it's
aluminum
just
blocks X-ray?
something.
Oh.
They probably don't want to get anything on the screen. They're like,
whatever.
but it's so freaking frustrating. And we're still seeing this everywhere. And it's like, when will this actually filter down to actual patients, actual experiences and outcomes? Like, and also
Right.
like, I mean, I imagine that clinic, like, I don't think they did a very good job if they kind of didn't care to do the follow-up because they probably just don't. Every system has like a bias for their own data. They don't want to deal with bringing in someone else's data. They just, there isn't enough push for them to make that happen. But like, they were ready. They had you on the schedule. Like you not showing up, then not being able to book that or like bill that appointment is also a loss for them. Like it's just dumb. It's dumb for everybody. It's dumb experience. It's
Yeah, and it's not
frustrating.
the technology's fault, by the way. The technology exists to make all of this happen. It definitely, I don't even know how
Totally.
policy or misunderstanding of policy. Like there's just
Yeah.
unpacking around why this isn't happening. It's also business practices and whatnot, whatever. People's interpretations of rules, but it's not happening, and we still have to fix it. So I'll be doing that
Yeah.
from the side now, and we'll hopefully learn a lot of things here that we can apply. But still
Hey,
gonna be working.
Alex,
Yeah.
listen. One, do you love Tefka? Two, what are you most excited about going to Oracle?
Okay, pass on the first question. Do I love Tefka?
Got
I
it.
think no. I am gonna honestly say like I some version of Tefka is necessary, right? And we absolutely need to be able to trust. We need to be able to exchange for all the reasons, and so that has to happen. I always say 3 parts of TEFCA that are necessary is the directory, the location, services, and the common agreement. That the cut part. All those things are necessary. CMS is building a national directory. It's going to be freaking fabulous, and it's going to solve some of those problems. But I do think that there are some modifications that can happen to TEFCA that'll, help get other players involved. So we need to look at that, and we need to look at the structure. We need to look at the trust pieces itself, and we need to figure out how to get payers more involved. So there's that. And I'm just super excited to go to Oracle and just learn a whole lot of new things and bring in the expertise that I have to share with them. And, next time I can maybe join the talk show with a very new perspective of what it's like to be on the implementation side of the house. I think that's going to be really awesome.
Yeah,
Will
well,
you
I'll also
ask
say, wait, really quickly though, Oracle, I will say, is definitely building up their policy group. Ashley, who was watching the show earlier, Aliza Silver, previously of Senate Help, super brilliant women are joining to work on really cool policy stuff. So don't count them out.
Yeah.
Don't count them
Don't
out.
cut them out.
Lots of policy geniuses.
And our friend, CEO Michael Muse, I was going to say Mucci, but I think it's Musey, from Arcadia. It says that the new AI EHR is super sexy. I don't know. No one's let me try it, so I don't know. But yeah, I will say, Alex, the last ask we have of you is, will you ask the SVP or EVP at Oracle who writes the unhinged blog posts if he wants to come on?
Oh yeah, make them come. Please, please.
Will you ask
need
him?
an introduction. We need an introduction. We're desperate.
Because
So
I would
once
like to be
once you figure that out, please, bring him on the show.
Yeah, we need to talk to that guy. We need to be like, listen, you're not even running the talk show, and you write talk show style LinkedIn posts.
He's ready.
Come here today.
Sounds good.
Okay. All right. Alex, any final words for our loyal fans?
Just looking forward to continuing talking. This conversation is going to continue forever, clearly. So
that's right. That's right.
But next time,
look at this girl. She's just doing the smiley face.
She's excited. You guys are going to be great.
She's excited.
Super jealous.
Okay, awesome. Well, congratulations, Alex, on your new role and your entry to the great free private sector, which is the best place in America and the world to be. And we will have you on later, and you can tell us all about it. Oh yeah, here.
Yay, Alex.
We want this. We want that guy. We want him on the show. Guy. So you call us later. Yeah, no problem. Yeah, so that's Chewy. Also, smiley face. So okay, all right. America. See you next week.
Bye.
It's
see you
the 4th of July.
See you in a few weeks.
America's birthday. So we'll see you after that. We'll see you later. Okay. All right.
That's right.
Good luck, Alex.
Bye. See you soon.
Bye.